Great. We just want to welcome everybody to the first webinar of the year of 2023. This one is going to be on PSPS neuromodulation webinar, both from the standpoint of both interventional and surgical complications. The moderator is going to be Dr. Kaz Emmerdelfan, a good friend and as well as mentor. And we're going to get started here in just a few moments. We're going to wait a minute or two here just to get people to sign on. While we're doing that, I will go over some household things, announcements, if you will. Next slide, please. Great. And usually with the the household announcements, it's a pretty cursory, thing to do. But I'm pretty excited here. And so for those who are just tuning in, I just want to make you guys aware that we do have some neuromodulation follow-up events coming up. The biggest one that we're going to be promoting on our website and social media is the one that's going to be taking place on April 1st, 2023. And this is going to be hosted in Portland, Oregon, led by our educational committee co-chairs, Dr. Samir Sheth and Dr. Vafi Salmasi. Biggest announcement is the first 20 fellows to register will receive free night hotel stay. We have a lot of great industry partners who are set to be in attendance, and we're looking forward to it. So we're going to be doing both didactics as well as actual hands-on learning at this lab. Next slide. A follow-up to this webinar that we're doing tonight is going to be one that takes place a little bit sooner, on March 14th, 2023. And this one's going to marry two separate topics. We're going to be talking about both patient selection as well as future expansions of indications. And oftentimes these kind of meet head to head and sometimes clash. We thought that it was imperative for us to bring this topic to our membership, both again from the interventional and surgical side of things, so that we push the envelope a little bit in terms of the etiologies that we're treating with neuromodulation, but also make sure that we stay within the precepts of what the evidence best supports. Next slide. Our second lab of the year is a really interesting novel one that we're going to be trying out this year, which is a two-tracked lab, which is both going to be interventional and surgical. So it's going to be on minimally invasive spine. And on the interventional side, we have our very own Dr. Drew Trainer and Jamal Lee. Next slide. And then also on the on the surgical side, excuse me, is our very own Dr. Dorsey, who's on the webinar tonight, and also Dr. Brian Su, who hails from Northern California. This is going to be taking place in Westminster, Colorado. There's a QR code on the left-hand bottom side of the screen for anyone who's interested in registering. For both the labs in April as well as June, we do encourage you guys to register as soon as possible and reserve your spot. Next slide. Quick announcement, just mainly for dates. This is pretty far out, but September 7th through 9th, so the weekend of 9/9. Make sure you guys mark your calendar. We're going to be having our PSPS annual conference, and we're switching it quite a bit. We're actually traveling further west than we ever have before. We're going to be hosted by our own very Dr. Eric Lee and Jonathan Carlson in Oahu. So please mark your calendars for this. And again, registration is on the left upper corner QR code there. Next slide. And along with that, we have a call for abstracts. So we obviously want to make this as evidence-based as possible, and we want to invite any late-breaking abstracts, research projects, both on the interventional as well as the surgical side, to be submitted for presentation. The deadline is August 1st of this year. Next slide. And I promise, Kaz, that we're coming to an end here. I know there's a lot to go over. But we have research grant proposals, which we're also accepting. So for those who don't know, we have a separate education committee that does give out grants for any type of tentative research projects that are out there. We've already rewarded two separate research grants from last year, 2022, which will be presented at our annual meeting. The deadline for this research grant proposal for 2023 is going to be July 1st. Next slide. So on that note, this is the agenda for tonight's events. I'm going to hand over the microphone and to Dr. Kaz Emmerdelfan to take over from here.
David, thank you so much. Good evening, everyone. Thank you so much for joining us. I have to say that I want to congratulate PSPS and all the officers and all the executives on the board that have worked so hard to make this society such an effective society. It's become a center for collaboration. It's become a center for education. And the testament to it is all these labs and all these educational programs that PSPS is putting together for all the physicians on the Western states. Aside from that, the collaboration between the surgeons and interventional pain physicians is inevitable. We're all becoming one big specialty together. So this level of communication is incredibly important for all of us. And we're learning from people local to us. I'm also excited about the annual meeting, and I thought it was winter time. I could just eat a little bit more and gain some weight, but it looks like I have to go back into my swimsuit weight again, so I have to go on a diet. I am an interventional pain physician here in Northern California. I've been practicing for about 23 years at this point. I've implanted thousands of spinal cord stimulators, and I've been privileged to teach fellows and work with other physicians. And sadly, with any surgical procedure that we do, there is a rate of complication. The good thing about spinal cord stimulation is that the rate of complication is really not that high. But when it happens, we need to be diligent, we need to be quick and recognize what the issue is. Tonight, we're going to talk about 3 of the most common SCS complications that may happen to any of us. We not only need to learn about it, but we also need to hear from the experts on how they manage it within their own practice and what the NAC guidelines say about it. So with that, we're going to go into the first one, which is infection. And I've got Ryan, Maddie, and Harjit Bandal to help me with that one. Next slide, please. Hi, Ryan. Dr.
Hey, Kaz,
Bandal, you can turn on your camera as well. Good to see you.
You too.
So I don't think so. Here we go. So this is the first case is actually a simple one. Patient has a trial. The trial goes well. They come in for a lead pool. And 2 weeks after that, they start to get some constitutional symptoms of fever and chills, some nausea and vomiting. They're calling your office and saying, I don't know what's happening. You know, I'm just having, I'm feeling feverish, feel like I've got like a heavy case of the flu. You have the patient come in, you look at the patient, and they've got a percutaneous, everything looks good. There's really just the puncture sites, not a lot of redness. There's no pus coming out or anything like that. But the patient is visibly uncomfortable. They're a little bit short of breath. They're just snip. And, but, no focal neurodeficits on your examination. What do you do with this patient? It's a trial patient.
Yeah, so 2 weeks after a trial, no signs of superficial infection, something on the skin, but you are thinking infection, right? Fever, chills, nausea, vomiting. That's going to come to mind. And anytime I have, concerns about infection, I think it's helpful to think about the procedure and helpful to think about everything that introducer needle and those external elements touch on their way into the epidural space, right? So where could this infection be coming from? So you've got the needle, it's going into the epidural space. Is this a spinal epidural abscess? It's getting close to the meninges, right? Is this a meningitis? We use the needle and usually touch down on the lamina before we enter into the epidural space. So is this vertebral osteomyelitis? Or is it something more superficial, just a subcutaneous infection? Either way, this is something that goes to the hospital. This is something that you don't want to wait on. If your physical exam may tell you a little bit more about where the infection is, neck pain, nuchal rigidity, headache, these are sort of more meningeal complications, spinal epidural abscess, back pain, or neurologic changes. So, this is something you have a concern for a deeper infection. As I would manage it, I would call ahead to the ER and let them know that the patient is coming in. Let them know what my concerns were. Let them know about that they had a trial 2 weeks ago, that these are their symptoms, and that these are some concerning signs that I'm worried about. Typically, you're going to get standard labs across the board, CBC with differential, ESR, CRP, blood cultures. Then you're also going to want some imaging, a CT or MRI of the head. If you're thinking meningitis, thoracic spine and lumbar spine MRI, if you're thinking about epidural abscess and vertebral osteomyelitis. I would also probably get a chest x-ray and maybe even a sinus x-ray because, if you are thinking meningitis, it could be coincidence. This is 2 weeks after the trial, and while that's, fresh in your brain, it could be, a different source of some meningitis. But from there, I'm letting the infectious disease doctors know that this is my concern, and they'll probably move forward with starting antibiotics, broad spectrum, and then going on from there.
Got it. That sounds excellent. That's a great plan. Um, I'm going to ask about some preventive measures from both of you after this, but Harjit, do you have anything to add to that plan? Would you do anything different?
Yeah, I think so. I think Dr. Maddie kind of touched on a lot of the good points there, and he kind of talked about a lot of the things that are recommended by the NAC guidelines. I think the main thing that the guidelines kind of also recommend are basically making sure first you kind of characterize the patient. If this is this a high risk patient or is this a low risk patient? So that means looking at their medical history, looking at are they diabetic, are they smokers, and a lot of the guidelines also recommend that you should test everyone preoperatively to see if they are kind of cultured with methicillin sensitive or methicillin resistant Staph aureus, because usually a lot of the times Staph aureus is the kind of the organism that gets deep down into the meninges or the epidural space. So patients who are high risk, who were already kind of colonized by those organisms, the guidelines recommend that they should be treated preoperatively, whether kind of using like an ointment for the nose or using a chlorhexidine wash. And then even in the post-operative, if they develop some sort of an infection, like here it seems like they're developing a deeper infection since the kind of the superficial site looks pretty okay, then you kind of have a sense of urgency to send them to the hospital, Dr. Maddie said. And then, yeah, most of the guidelines recommend getting the blood work like CBC, blood cultures, ESR, CRP, although there is a little caveat there. Although this patient is 2 weeks out, a lot of those markers may be elevated in someone who just underwent some sort of a procedure, or a lot of our patients already have underlying like rheumatological diseases, so their ESR or CRP might already be elevated at baseline. But getting blood cultures, especially if they're febrile or they're starting to show kind of meningeal signs with things like backache, neck stiffness, blood culture should be obtained. But the guidelines recommend that you shouldn't wait to start any sort of a treatment for the blood cultures to come back. So it's okay to start empiric treatment before the cultures have come back. And it's always good to kind of get infectious disease involved early if you can. So getting that consult, if you have a friend at the hospital, giving them a call, getting them on board at the ED, so they can kind of better characterize the patient and determine if this is just a superficial infection for which the guidelines recommend just kind of doing oral antibiotics and observing for 7 to 10 days, or is this more of a deeper infection, which you can kind of figure out by using imaging like CT or MRI, checking for abscesses. And if this is a deeper infection, it may require a surgical consultation to go in there, drain the abscess, culture the wound, and then start kind of targeted antibiotic therapy.
Yeah, I agree with both of you that we have to act quickly with something like this. We need to at least get the imaging and make sure that there's nothing more serious going on. But I always say the best way to treat an infection is to prevent one. So I want to know, in your practices, do you actually use any pre-op antibiotics for your trials? Because I'm sure you do it for the permanent implants, but what about the trials?
Personally, yes, I do preoperative antibiotics, and I actually do antibiotics throughout the trial because most of my trials last usually 5 days, between 5 and 7. And I've looked at the literature and specifically the Holzer study from 2017, looking at spinal cord stimulator infections. And what they actually found was that trials that went on longer than 5 days had a higher likelihood of infection, not actually during the trial, but when they went on to further implants. So whether that's due to some kind of seeding or just the initial exposure. So knowing that evidence, I do put people on antibiotics during the trial, and it's something. It's still, Tim Deere put it best. He said antibiotics during trials. The information on that is about as clear as mud. So some people do use antibiotics during trials, some don't. A lot of it, comes down to where you trained, who you trained with, what your experience was. And I was with Lawrence Perret up at UCSF, and he was very regimented about the antibiotic use throughout the trials to do everything you can. He said, exactly as you put it, Kaz, if the best way to avoid an infection is to prevent one.
Absolutely. Harjit, anything to add? What antibiotic do you use pre-op for your patients?
Yeah, so usually the most common kind of organisms that we talk about are gram-positive organisms that kind of cause the infection. So usually like a first generation cephalosporin works pretty well. Now, of course, if the patients are, have colonized with MRSA, then you would want to use something like vancomycin. Although the NAC guidelines do recommend to try and limit vancomycin use as much as possible, just because you don't want to create a bunch of resistance in the patients. And the NICE guidelines, you know, although this is not my practice, but maybe I should change it after looking over the evidence, but they don't recommend antibiotics for more than 24 hours after an implant or a trial. And that's kind of what a lot of the surgical data also shows from prosthesis or spine surgeries or implanted cardiac pacemakers, that after 24 hours, the antibiotics really aren't needed.
Yeah.
I do not do any antibiotics beyond 24 hours with a closed incision and an implanted device. But there is a potential nidus for infection when you have an external lead internalized into the epidural space and it's staying like that for, you know, 5 days or sometimes a week. So I do think there's a little bit of a difference there. And, you know, this is probably where we're getting into the nuance of individual practice.
So I will tell you that in my practice, you know, despite the fact, I don't know that Dr. Deere has his opinion about these things, but I think pre-op antibiotics are incredibly important because the patients could potentially be immunocompromised if they're smokers, if they have, you know, a previous history of alcohol abuse and all that. They're more prone to infections, despite the fact that the period of the trial is a little bit lower. I would agree with him that the post-op antibiotics is really up for grabs. You know, everybody has their opinion about this. I do use antibiotics for 2 or 3 days post-op with my trials, but I think that's more CYA than it is scientific fact. So thanks for that. Let's go to another case real quick and see what your opinion is about this one. This has happened to just about all of us. What I always say is that if you haven't had an infection with an SCS implant yet, that's just because you haven't done enough implants yet. And it's the absolute truth. No matter how good you are, no matter how good your sterile technique is, and how you close and how you irrigate, you're going to get an infection at some point or another. So in this particular case, the patient comes in a few weeks after the perfect implant that you did. The wound looked great. They took the sutures out. There's a lot of redness around the wound, and it looks like there's some pus coming out from a corner of it, you know, and it's the midline wound and not the pocket on the side, but it could be that too. So let's go with Harjit this time around. We'll go with you first. What do you do with this patient?
Yeah, so I think you know, the fact that the wound is at the midline wound and not the pocket wound, that's a little bit more concerning, because you know, we know as far as infections go, you know, it's usually the pocket site wound that gets infected the most. So for the recommendations for that, if it's kind of, again, a superficial infection on the pocket side, you know, you just do oral antibiotics, watch the wound. If there's kind of purulent material coming out, you can culture it, so you can, again, better guide the antibiotic therapy. But when it's the midline wound, I think you're a little bit more concerned that this could maybe seed into the, you know, the bone, the epidural space, the meninges. So for this patient, I would, you know, definitely kind of, again, start the workup with all the lab work. I would send them for imaging, kind of stat, get a CT or an MRI to rule out any sort of abscess that's developing, and then also think about, you know, explanting device. Because a lot of these patients, and the data shows, you know, when the device kind of develops a biofilm around the leads, it just becomes a nidus for infection, and it's difficult to clear that biofilm with just oral antibiotics. So you can, again, open up the midline wound, do really kind of copious irrigation with saline to try and clear out the infection. Again, you can culture it, guide the antibiotics to it, and then I would also think about you know, getting potentially maybe a general surgeon colleague involved to see if any sort of tissue needs to be debrided, and then potentially kind of closing the wound with either you know, a wound vac, or consider leaving it open, putting a drain in, trying to do anything you can to, you know, to kind of get rid of the infection. But ultimately, I think if I have any sort of doubts that this could be something bad that's brewing, I think taking out the device and explanting, I would have kind of a pretty short, you know, leash to kind of go for that.
I think you should get a free night at the hotel at the annual meeting, just for that answer, because that's exactly the right thing to do. Ryan, let's see if you can get a hotel room as well.
No, I completely agree with Harjat. You have to determine if this is a superficial infection versus a deep infection. The bigger concern, and he's right, is that midline incision, because now you're not isolated from the neuraxial space, right? So the potential, that is a much less safer space for an infection to be brewing than in the IPG site, which is often, look, if it's confined to the IPG without involvement of deeper layers, isolated from the neuraxial site, he's right. You could probably try some oral antibiotics and you know, see if you can get them through it. But when there's concern for a neuroaxial spread of infection, I have a low threshold for explantation. It's just somebody told me once, it's not if you operate long enough, you do these devices long enough, you're gonna get complications, and it's not getting the complications, it's how you handle them.
Was that someone me just a few minutes ago? Because that's what I said.
I know you've said many things, so many things over the years that have stuck with me. I'm sure it's probably from something that you said at some point.
Yeah,
But
I
would
think it's yeah. Go ahead, finish your thought.
yeah, I
Sorry.
would just say not to hesitate to to surgically debride and the wound and explant the device if the clinical picture is suspicious for a deeper infection. You have to do it. It sucks. You don't want to do it, but it's the right thing to do for the patient.
There's no question. So let's not forget, and this is my profound statement that I teach at fellows courses and all that. We are elective surgeons. There's nothing that we do that's an emergency. So if you've implanted something and if you suspect that the infection is deeper than just the skin, you've got to explant that device. You cannot take the risk. But if you think that it's just a superficial infection, it's on the skin, and you want to treat it as such, give the patient antibiotics, make sure they have your cell phone number, make sure you have communication with that patient on a daily basis, because you may have to pivot very, very quickly. Okay, so I will tell you, I mean, there's been occasions that I was about to go out of town and I had the patient come and see me like 2 or 3 days before I was about to go out of town. And the night before I left, I had to explant the device, mainly because of the fact that the pocket was infected. And I love both of your points on this, that getting a surgeon involved is really important. Harjit said this. I used to bring this plastic surgeons in with my first couple of infections to see how I can use the curette to take all the macerated tissue out and bring healthy tissue in so the pockets can actually heal and we can come and fend for ourselves on another day. Excellent. Thank you guys so much. I think we covered quite a bit with infections. Now we're going to move to the neurosurgeons and talk about some of the complications that can actually happen in the epidural space. Thanks, Harjit. Thanks, Ryan. Michael and Stephen. Dr. Michael Dorsey and Dr. Stephen Albano are going to join us for the next case. Do we have the case up there? Hi, guys. How are you? Thank you for being here.
Thanks for having us.
So here's the first case. So you see a patient, perfect patient for a spinal cord stimulator, but you feel like a paddle is a better way to go because you're surgeons and you can actually cut down and do a laminotomy and place the paddle right over the dura. Okay, so you do the paddle. It's fairly uncomplicated. There's really nothing. But post-op, the patient is starting to have some headaches, and they have, and it seems like it's a post-spinal headache. They lay down, it gets better. They sit up, it gets a little bit worse. There's no fever or chills. There's nothing like that. The wound dressing looks very dry. It's not a lot of drainage, but there's some weakness in the lower extremities, and the patient is just not looking as well as they usually do after a surgery that you guys do. So how would you handle this? Michael, let's go with you first.
Well, the initial findings, once there's any kind of neurologic question, the answer is go to the emergency room. So this patient is going to the emergency room just based on the generalized weakness in the lower extremities, because the differential here is compressive pathology affecting the spinal cord, whether that be infection, whether that be blood, whether that be spinal fluid, whether that be seroma, whether that be the actual paddle. That's the number one differential that needs to be ruled out. So that's the first. So they'll go to the emergency room. We'll get a better examination, get a detailed neurologic examination, and really document what their weakness is. And oftentimes these are evolving situations. The 1 or 2 epidural hematomas I've encountered over the years have been, luckily the patients have got there when they just started having some tingling in their feet. But within an hour or 2, these can really ascend and become a much bigger problem. So once they get to the emergency room, imaging is the next thing. And I would say when you make that phone call to them, telling them to go to the emergency room, you have to tell them to bring their programmer, because a lot of the stimulator devices we use, if we're lucky enough that they're MRI compatible, they do need to be put into MRI mode. And if you can't put it into MRI mode, then you're going to have trouble getting the MRI. So they need to bring their programmer always. And then the next step is to get an MRI. Now, if you can't get an MRI, a CT scan will suffice, but you need to know that the CT scan is going to be very limited in its resolution, and often hematomas can be missed, and you can't really say anything about the spinal cord from a CT scan. But if we get the imaging, and I think our next slide shows some imaging of this patient if it got entered in.
So Stephen, when Michael is talking about the CT scan, what kind of a CT scan should we be getting if this is the issue? Should we put any contrast in at all, or?
When we're considering compressive pathology, a CT myelogram is actually extremely helpful, and then that way you can kind of distinguish if it's something from a paddle potentially, since you're trying to place it in that epidural space. And so if it's something associated with that, then the CT myelogram would show kind of potentially an occlusion at the area where you put it. You can see how compressive it is.
So answer me this, gentlemen. So I'm an interventional pain physician, and I don't go into the hospital, because there's sick people there. We do all of our cases at ASCs and stuff. Is it fairly easy to get a CT myelogram through the ER if I send a patient to the ER?
It is next to impossible to get an urgent CT myelogram. And the cruel reality is that once you get away from major centers, I work at several hospitals where you can't even get an MRI after 5 p.m. And so you have to know these limitations in your system. And again, this is someone, if they're having progressive neurologic symptoms, you're not going to delay and transfer. So if you can't get imaging, then you're thinking of acting more acutely on the actual clinical symptoms.
And would you recommend that, all the interventional pain physicians have a neurosurgeon that they have a good relationship with, basically just call them up and let them know that this is what's happening and confer with them as they're sending the patient to the emergency room?
I think that's definitely should be the case. There's always going to be a neurosurgeon on call at any legitimate emergency room, and any neurosurgeon on call should be able to manage this. But it is a very nice heads up, and if you know the person who manages stimulators in your area, we'd like to be called on this because we're used to managing these complications more so than just whoever's on call. It might be a brain person.
Got it. So what are we looking at here in this picture?
So I'll let Dr. Albano take us through these images.
Oh, gotcha. All right. So in slide A, it looks like a sagittal T2. And so where you're looking at the white arrow, that looks like kind of some artifact from the actual paddle lead placement. And then this
Stephen,
kind of black
I'm
arrow.
going to interrupt you for just 1 second. So you said sagittal T2. Could you explain really quick the difference between T1 and T2 for our audience?
The quick way to tell is white is fluid. So this CSF kind of going down the column, that's where we look to see if there's compression. And then the black part within the white column or that CSF is your spinal cord. So I'm looking to see if there's something compressive given the patient's history. And so those black dots pointed out by the white arrow is likely the paddle. And then you can see white fluid kind of almost contiguous with that CSF column coming posteriorly. So that would be concerning for a CSF leak. Given the history, if they're having positional headaches, then that would be kind of your leading differential at this time.
And
as far
the treatment, go ahead, finish your thought. Sorry.
So just the center slide, the B panel is showing the axial. You can kind of see the CSF pocket is white. And then the far right, the C slide or the C panel, you can see that the paddle is kind of in position in midline. That one's a little harder to tell with CSF. It's just usually for positioning, but it helps you identify where it is. So if you do need to do something surgical, you're going to have to find where that leak is. And so that's where having that relationship with the person who put it in can be very helpful. If they noticed anything during the surgery, what level they put it in under, how they placed it, if there were any complications that they noticed. Some people place these a little differently. Some people do a full laminectomy and place it on top of the dura. Some people do kind of a hemilaminotomy and slide it under the lamina and go up. And so some of that information is helpful in kind of figuring out your surgical approach if something needs to be done.
Yeah, and if I could add to Dr. Albano here, with a surgical paddle lead, CSF leaks are exceedingly low, largely because it's a thoracic laminectomy. It's not a stenotic area. And so when we talk about lumbar surgical durotomies around 5%, those are on stenotic spines where there's ligament deflatum stuck to the dura, and the dissection can be quite tedious. In the thoracic spine, it's rarely the case that we're doing a thoracic laminectomy or laminotomy and really encountering much scarring, but occasionally there can be, especially if it's been a long time since the trial. And so you can't. This MRI tells us that at least the leak is in the thoracic spine, as opposed to being leaked down from where the trial was done, which could also be in the differential if this was done right after the trial. But it doesn't tell us exactly where along the course of the paddle electrode that the leak occurred. The most likely spot is at the entry point where there could be jagged bone edges, but it could also be along the more rostral part where the paddle was slit up. So it tells you where to start, but it doesn't tell you exactly where you're going to finish. You may be doing multi-level laminectomies here to get to the actual leak.
Wow. So is the treatment repair of the leak, or is it explantation of the device and repair of the leak?
It's both. You wouldn't want to have. I mean, you can see this paddle is it's floating. You can see it in the middle picture here in the axial. I think this little septation that you see towards the back of that big fluid pocket might be part of the paddle. And when you look at this AP image, you can see that it's way off to the side. That's not a useful paddle position anyway. So hopefully that's because it floated in CSF and moved around. But you wouldn't want to leave anything that could be compressive in a leaking spinal canal, because you're losing that cushioning that you get from the CSF when you have a leak. And so you don't want to take any chances and leave anything behind that could be a secondary injury to the spinal cord in someone, especially with neurologic symptoms.
Got it. Excellent. Thank you, gentlemen. I have one more case for you before I let you go. We learned with percutaneous lead placements to go quite shallow with our needles, but time and time again, a lot of physicians insist on going a little bit more vertical. Their angle to the epidural space is more obtuse, and as the lead comes out, sometimes it can potentially injure the dura. So now we have a percutaneous case. The patient goes into the OR. The case is going well. The doctor gets loss of resistance with his needles or her needles, and the leads go through. No problem. There's no CSF coming out or anything like that. The leads are very dorsal on the lateral picture. The case is done. The patient comes out and they're sitting up in the recovery room and they have a bit of a headache. And the headache's getting worse. And when you lay the patient down, the headache gets better. When you sit them up, the headache gets worse, and you send the patient home thinking that it's going to get better. 2-3 days later, it's still ongoing. And it's becoming a problem because it's really bothering the patient. And the patient's getting dizzy, they're getting dehydrated, they've had all the caffeine in the world and they've stayed flat as long as they can. What do you do for this patient? So do you want to go first?
I mean,
so it's a percutaneous lead placement that potentially injured the dura for you to have a leak at this point.
So what you're describing is the positional headaches. I mean, obviously it's concerning for a CSF leak. The concern is if you punctured the dura, then I'm not sure where that percutaneous lead ended up. So they could potentially be intramedullary. And so your physical exam becomes pretty important to make sure they don't have an injury. You're still going to get imaging because we still have to rule out other things in our differential. So your imaging, usually you lead off with the MRI. If that's not available or if their device is incompatible with an MRI, then where that CT myelogram comes into play. To your point earlier, not everybody has CT myelogram. And so a plain CT, some people do it with contrast, but the displacement of the lead can be suggestive of an epidural hematoma if you're thinking along those lines. And then as far as this case, you might see it within the canal, and it could be intramedullary potentially. But in terms of management, we want to see kind of where it entered potentially on this CT or this MRI, because if you're going to fix the leak, you kind of want to know where we're trying to target.
Got it. Michael, can I do a blood patch on this patient?
Absolutely. Yeah, I would say, it's been a few days now and they've been leaking, so they might have a rather big fluid collection back there accumulating. So I would favor you sending this into the hospital to get imaging of the brain in particular, because if you've been leaking for a while, you could have some brain site, could have a subdural hematoma from persistent CSF leak. Ruling that out, and then I would say have IR drain the fluid and do a blood patch as the first treatment. If that fails, then surgery becomes an option. to fix the leak.
Yeah, that sounds great. So the take-home message is a workup is absolutely necessary before we treat this. It can't just be, you can't just assume it was a dural puncture. It may be something a lot more serious than that, and it needs to be worked up. If it's just a percutaneous trial, you could remove the lead and do the imaging. But if it's a permanent implant, then obviously the workup becomes that much more important. Excellent, you guys. That was wonderful. Any last words before we go to the next couple of cases? And don't go away, because hopefully the audience will have some questions for us.
I just encourage any surgeons on the call tonight to register for the Surgeons Lab. It's going to be a great event beginning of June in Denver.
Okay, great. Thanks, Michael. Stephen, anything? Any last words?
No,
let's give
we
you
can
the
actually
last
skip
word.
these slides just since we discussed most of it.
Sounds good. All right, very good. Now I'm going to invite Jennifer Lee and Roya Mohimani to come online, and we're going to talk about some bleeding and seroma. And as we're talking about the bleeding and seroma, hopefully the neurosurgeons can chime in and talk to us about those as well. Hello, ladies. Thank you for joining us. Really, it's an honor to have you here. So I've got a couple of cases for you. The first one is actually just a bleeding case. So a patient presents the surgical dressing less than 24 hours after the SCS implant procedure has been done. The case went well. There was no issues. You didn't see any blood at all. There was no sort of oozing from the wound or the pockets or anything. But the patient comes back to see you, and they're doing well. You just look at the dressing, and sure enough, there's like red blood, not dry blood, but red blood on the dressing itself. And it's getting soaked, and it's starting to come up from under the dressing and around the elastic and the tegaderm that you have on there. The patient had stopped the anticoagulation per the ASRA guidelines, but resumed them per your instructions today. The neurological examination is actually normal at this point, and the patient is doing well. It's like, thank you, doctor, things have gone well. What do you mean there's blood on my back? So what do you do with this patient?
Hello, thank you for the great case. So for this patient, I think the first thing I would say is that this would be a case that I assess my patient personally. I think a lot of times for these postoperative inquiries and appointments, we enlist the assistance of our physician assistant and nurse practitioners. This is definitely a case where I would put my own eyes on the patient. In this situation, the differential diagnosis is whether this is a local pocket hematoma alone, or, I would say that if we're seeing such a robust bleeding locally, I would also have a really heightened suspicion and be really keen to any neurologic signs that there were bleeding that were occurring in the central neural axis as well. So I would be meeting with the patient, kind of reviewing whether there were any additional patient risk factors for bleeding, talking to the patient about whether they had remembered to discontinue aspirin if that were the case, if that had been a medicine they were using, and also reviewing if there were any herbal medications that they had neglected to discontinue. I would be assessing the patient physically, looking at the site, of course, and trying to estimate the volume. That could be very difficult, but still something I would pay attention to. I'd be looking also at the other surgical site in the midline to see if there's any evidence of bleeding in that location. I'd be performing a very thorough neurologic physical examination, specifically looking for any evidence of epidural hematoma. So looking for hyperreflexia, clonus, Babinski, talking to the patient about symptoms of motor weakness or incontinence. And if those things were not present, what I would be doing is talking to the patient's prescribing doctor with respect to the anticoagulation and assessing the risk for the patient to hold resumption of that medicine for a day or two longer until I get a handle on what may be happening. My preference would be to hold that medicine if it were safe for the patient for a couple of days until I have an opportunity to know if this is something that's going to go back to the operating room or not. If all is clear, if all kind of pans out here, the neurologic exam is intact, and hopefully the prescribing or the physician who is directing the anticoagulation has guided me. I would be placing a compressive dressing or using an abdominal binder for this patient and having him or her return to the clinic within 24 hours for a reassessment, and also providing that patient with my personal contact information for emergency.
I think that's key, Jennifer. Thank you for mentioning that. I think it's really, really important to monitor this patient very closely. To your point, the patient may not be at a lot of risk, but the fact that they have the insurance of having your personal contact information, the fact that you're seeing the patient on a daily basis is exactly what we need to do to ensure that this is not going to become a major complication. So, Roya, what about you? Would you do anything different?
No, I mean, I think Dr. Lee makes really good points. If you want to be really academic, you can try to do coagulation studies. If you have their medical history already, then maybe that's already been done, but perhaps this is like a coagulopathy that you're discovering in the patient. And then per NAC guidelines, I guess they technically have to wait 24 hours to start their anticoagulation. So I guess maybe there was, because it said that the change is less than 24 hours. So they should have waited. So then I would try to figure out what was done in the instructions. They probably should have held it till after the 24-hour mark.
I think that's a very profound point. So I found in the 23 years of my practice, I find that the post-op instructions that I give to the patients basically stays in their folder, in the packet of things, and they don't really read it, especially in the post-operative period. So it is really important for all of us to instruct the patients on how the post-operative period should go before they even go into the OR to do this. So I usually do that in the office, and I give them the post-op instructions the day that we're talking about scheduling the permanent implant for them to become familiar with it. Because no matter what you say on that, and no matter what you tell them that day, there's so much going on, and they've had sedation, they may forget, and they get home and they want to take their medicines because they're worried about their anticoagulation, because they have heart issues, arterial issues and all of that. So it's a very profound point that, the patients sometimes forget and they start these medications a little bit too early, and we need to instruct them far better than what we do. So how long does the NAC guidelines say that we should wait on anticoagulants before the patient has basically normalized? Do you guys know? I mean, there's different days for different things, but there's a general guideline with that.
I mean, each of the anticoagulants has a different length of action, but as a rule, it's 5 half-lives.
That's right. That's exactly
And I have
right.
a slide that like kind of summarizes all of this. I don't know if we have time at the end. I can show you the slides I made.
Sounds great. So let's. I want to see if Michael and Stephen have anything to say about the hematomas and what we need to be watching out for before we go to the next case.
I think they cover this very well. Just a heightened level of suspicion. I think this is a very benign presentation at this time, and likely will stay so.
Okay, sounds good. All right, so this other patient is.
Go ahead,
sorry, Stephen.
Mm-hmm. Prevention is the best thing. Then we don't have to take them back to evacuate any hematoma. So in terms of preoperatively, also just discontinuing any antiplatelets for at least 6 days is part of the NAC guidelines. And then they always recommend multidisciplinary discussion with whoever prescribed it for what the reason they have it is, just because sometimes people can have events if you take them off, and then if you wait too long to restart them afterward. So it's just, we want to have a good reason for stopping it, and we want to be sure we're stopping it at an appropriate time so we don't cause more harm.
That's right. That's a very good point as well. We should not be the ones to instruct the patients to stop their anticoagulants. That needs to be done in collaboration with the physician who prescribed that anticoagulant for the patient to begin with. The 5 half-lives is exactly what the NAC guidelines recommend to us, and we need to follow that to the T. I think that's really, really important. The other thing I wanted to mention is that even for the percutaneous trials, during the trial itself, I don't typically allow my patients to take their anticoagulants. If they need a bridge dose of some sort like Lovenox, I let them do that, and I have them stop it 24 hours before I pull the leads. The reason I do this is because I've seen this with my own eyes. I've done a ton of animal studies for various research projects with neuromodulation. And within a day or two, there's angiogenesis around the active contacts. So as the active contacts get scar tissue and angiogenesis around them, if the patient has begun taking their anticoagulants and you pull that lead out in a very benign manner in the office, you could potentially cause a hematoma just by pulling that lead. So it's incredibly important for the patients to be very, very safe, even with the percutaneous trials. Now, this is a seroma case. The patient presents post-op day 10, well-healing incision, really uncomplicated procedure, but the patient fell the day before. Now they're showing up to your office, and it looks like there's a lot of swelling around the battery because they fell on the battery. It's getting a little bit red. There's no fever or chills. It hasn't been growing. It happened immediately after the traumatic fall. And there's, a little bit of erythema, but and no tenderness at all. So, but you see this fluid-filled pocket just beneath the skin in that area. And what do you think about this?
Well, I have the luxury of this case being titled seroma. So if I were actually seeing this patient personally without that lovely prequel, then I would be really looking once again broadly at a differential diagnosis. Of course, seroma is the most likely scenario here, but the other possibilities include an infection or a CSF leak that is tracked back from the central entry point. So once again, going back to the patient's history to identify if there are any risk factors that should further heighten your suspicion for either of those situations. Postoperative day 10 is right in the time frame where infection would be presenting itself, and I have no reassurance by a patient telling me. I'm not in any way reassured if a patient says that they don't have any of the constitutional symptoms. Many of the patients that we're doing these procedures on are elderly, and those constitutional symptoms are not going to be evident, and we really can't depend on them. I would have to, once again, see this patient personally to examine the wound, look at any signs of erythema. If there is even the faintest erythema, mark it with an indelible marker, and also be looking at any surrounding tissues, even distant over in the flank, lateral to the site of the IPG, tracking my examination to the central neural axis, and querying the patient really substantially about any discomfort, any tenderness in either location. For this patient, I think that in honesty, I would get some inflammatory lab work to reassure myself, and also so that if this continued or if there was any question at a later time about the more erythema or the presence of some vague constitutional symptoms, I would have some sort of a baseline to look at. But if all of this were the case, neurologic exam were reassuring, and everything else, including return of the inflammatory lab work, were as well, this is a case that I would once again place a compressive dressing or advise an abdominal binder. I'd also be, I'd be thinking about my surgical technique, considering how large was the pocket, because any dead space is opportunity for a collection of a fluid. So it's really, I think, in this scenario, an opportunity to look back and let the history guide, your the direction and the significance of your investigations for either of these differential diagnoses.
Excellent. Roya, would you do anything different?
Actually, a random idea. I don't have any personal experience, but a mentor of mine, actually, he had his first infection and he mentioned ultrasounding the pocket.
I did that one.
Looking for evidence of pus. I think that sounds amazing. So I think, when I encounter that, that's something I'll consider. Obviously,
I love that.
I think the thing is that, and the time that I did that, it was, it felt good because it was something I could do, another investigation when my mind was turning with the possible differential diagnoses, but I don't think it didn't really influence me one direction. It was not going to be decisively going to change my my treatment.
Roya, I love the idea of the ultrasound, especially nowadays, since most of us have an ultrasound machine in our offices, so we can really easily put it on there and take a look and see what we see in there and what's going on. If there's loculations and all that, then obviously it could be an infection in that area, so those things really need to be checked out. But I love the way both of you think. So how many times have you had a patient refer to you and the doctor says, you know, this patient has failed back surgery syndrome, for example, and needs a stimulator. You know, the referral says that. And the patient comes to you and you start to evaluate the patient and you see, I mean, although the patient has had a fusion in the back, the problem is a sacroiliac joint, you know. So despite the fact that sometimes there are hints that what the diagnosis should be, we should really think about the differential diagnosis. You know, Jennifer, you pointed out the case of seroma, but I love the fact that you said we have to think about the entire differential diagnosis on these patients and see where it's gone. And I love the way both of you are treating this particular patient. Here's a question for you. Would you put a needle in there to draw it and see what's in there?
So I guess that's my thought with the ultrasound. I would not put a needle in there. I would not open this wound unless I had a real significant confidence, either in my inflammatory laboratories trending, or if I were to have obtained an MRI and had evidence of infection. I would not open this, regardless of if I saw ultrasound fluid that was, that was variegate and had proteinaceous material within it.
Got it. Roya, what about you? Would you
I
put a
agree with
needle
Dr.
in there?
Lee. Yeah, I just don't like the idea of anything that could be infected sticking a needle in it.
Exactly. And that's the take home message. You know, it may be a sterile amount of fluid in there that at some point will get reabsorbed with compression dressing, with time, with observation. The last thing you want to do is put a needle in there because you can very well infect it. Then you really have to deal with an infection like spot the whole device. Excellent answer. Thank you. Roya, you said you had some slides as well. Is that right? Do you want to go through your
Yeah, I mean,
slides?
I would just do it really quickly if we have time, but I don't know if we want to
You
have
bet,
questions
we do.
instead. So basically with NAC, they talk about doing that shared decision making with holding anticoagulation, and then the rate of epidural hematomas is about 2.5 to 0.3%. So I thought that was kind of reassuring. And then if you stop here, this is the one, if you go back, well, just to summarize. So NSAIDs, it depends on the NSAID when you're going to hold these guys, and basically phosphodiesterase inhibitors 2 days. Coumadin, you want to hold it for 5, check an INR. Things like Plavix, 7 days. NOACs, 3 to 5 days. So rivaroxaban and apixaban is going to be 3 days that you're going to hold it. Aspirin is always interesting because for primary prophylaxis, it's 6 days, and then secondary, if it's secondary, then you do shared decision making. So I thought just having this general in the back of your mind, and then consulting the NAC guidelines, looking at the actual table before you do it if you ever have any questions. And so this is for the entire trial and 24 hours after the pull, as we kind of discussed, and then obviously 24 hours after permanent implant. So that was basically it. I just wanted, the guidelines on that paper are great. So having that table in your clinic is probably helpful just to consult if you ever want to check it.
I love it.
I would underline
Thank you for that.
no INR too. I think we've all been surprised now and then when we hold our Coumadin for the expected length of time and the INR remains high. And there's a lot of the herbal supplements, aloe, chamomile, garlic, cranberry, that all extend the length of action of Coumadin. And so those things have to be considered. The INR needs to be checked on those patients.
Thank you for that. Dr. Lee, Dr. Moimani, thank you so much for those presentations. Don't go away. I want to ask all the panelists to come on and answer a couple of questions here. So the first question that I'd like to bring up is that if a patient actually has neurological deficits and they're going to the ER because they have neurological deficits, is it even worth it for us to get any imaging, or should we just go straight to an explant? I want to ask the neurosurgeons to comment on that.
Yeah, I think I just answered that on the side chat as well. I think it's if it's easy and convenient.
I'm the only one who reads the side chat, doctor. Answer the question.
If it's easy and convenient to get the imaging, meaning you can get it, the patient rolls in, they get checked in, and they can get to the scanner, then certainly do it, because the pathology can span quite far above and below. I've seen it with especially with percutaneous leads. I've seen 8 or 9 level epidural hematoma that if I would have just went to the entry point without any imaging, I would have done a minimal laminectomy and not fully decompressed all the levels. I've also seen it where we couldn't get imaging because it was an MRI non-compatible device, where I went in and took out the paddle and decompressed right at the level, and then went right to scan from there and right back to the OR to do additional levels of decompression. So it's certainly useful, but you don't want to hold up your treatment.
Steven?
I think a lot of it too is how quickly they're decompensating. So if it's like immediately after surgery and that's kind of your leading diagnosis, if you don't have another reason, then you can take them back. But if it's something kind of you're not sure of the diagnosis or you have a little bit of time where it's kind of a slow progressive thing, if you have it, you should get the imaging because it does provide you additional information that's helpful for surgical planning. But if they're acutely decompensating, and you got to do something.
Yeah, the take-home message is that neurosurgeons love imaging, and they should, because it's really important. It guides them into what it is that they're going to need to be doing on this patient and what the anatomy looks like. So here's a question for Harjit and Ryan. We missed you guys. You started us. You can bring us home. So the question comes from Dr. Shaw, that is a capsulectomy or fenestrating the scar tissue necessary if you're doing a revision or a replacement of an IPG or a pump? What do you guys think?
I mean, I think it depends on what it looks like once you get in there. Sometimes the capsule, if there's just sort of blood in there and it's been a hematoma, that there will be significant sort of subcutaneous changes that look pathologic in a way. They're actually quite benign. In which case you would need to do a capsulotomy or capsulectomy. If you are talking about, hey, an infection that has been cleaned out, you've been explanted, and you're talking about reimplanting, then you have to find another location for that. If and when the patient reaches a point where they've fully recovered and fully healed, and even at that point, I would still probably have an infectious disease consult ahead of time to say, hey, we're good here. That infection is cleared. They're not at any increased risk at this time. But you would need to look for another site.
Got it. Harjit,
Yeah,
anything to add?
I think it would just kind of depend on what it looks like Dr. Maddie mentioned, once you kind of got in there. I don't think the guidelines don't say that it's needed, but I know, if it is kind of, an infection, the other thing to kind of consider would be using like vancomycin powder. Although the risk for seroma formation is there, but there is good evidence that, not to use it on every case, but if it is an infected kind of an area, to use that when you're kind of doing your initial cleanup and closing of the wound if there's concern for, MRSA. So that's always kind of a good thing to do as well. And then the NAC guidelines, also don't, or they do recommend, reimplanting a device, even if it was taken out for any sort of an infectious reason. So I think, using maybe a different site for that reimplant would maybe make more sense, and not just go back to that site just in case.
Okay, so I would respectfully disagree with both of you. So you went down a potential complication. If you've explanted something and you're going back to reimplant, by all means, you want to use a new site. But if you're just doing a routine IPG replacement or a pump replacement, I was a microbiology major in undergrad and did a lot of microbiology research. That scar tissue is avascular, and in order for you to be able to get antibiotics to a pocket after a replacement, just in case there's any sort of contamination, you need to do a bit of capsulectomy. You don't need to open the capsule all the way, but scoring the capsule itself to allow some vascularization of that area, to allow the antibiotics to actually reach the implanted device is incredibly important. So in my personal opinion, you don't need to do a full capsulectomy and just have fresh tissue everywhere, but you need to at least score it to allow some vascularization for the antibiotics to be able to get to that area. I would not use vancomycin powder unless there is there's really no evidence for vancomycin powder inside the pocket itself. Vancomycin for an MRSA patient is important pre-op, and maybe even post-op it may be necessary. But if you don't know if you're treating MRSA or not, putting vancomycin powder inside the pocket really doesn't have a lot of evidence there. So that's my answer. Does anybody else have anything to add to that? Because we're right at the bottom.
Yeah, I would just say that I agree with you. I misinterpreted it in terms of doing a capsulotomy or capsulectomy in the context of a general IPG change or a battery swap. No, you put it right back in the same spot and do exactly what you said. I was interpreting the question as, is there a complication within that pocket
Yeah.
that we're addressing.
Absolutely. So I'm sorry, I must have not asked the question right. 2 years after my fellowship, I'll never forget. Then we had an IPG replacement that my senior partner had implanted, and he's like, "Cass, do this replacement for me." I was like, "Yeah, no brainer. It's going to take me 20 minutes to do this." Went in chest up like this into the OR. Did the case, went perfect, took 20 minutes and all that. And 3 weeks later, she developed an infection, and we had to go back and explant the entire device after she had a successful implant in the past. And I'll never forget that case because, we had to explant her and I felt incredibly disappointed. And I talked to some plastic surgeons after that because the plastic surgeons can really help us with all this subcutaneous surgery that we do. And the first question out of the plastic surgeon's mouth was that, well, did you open up the scar tissue at all? Or did you just take the IPG out and put it? I was like, I just took the IPG out and put a new one in. And he's like, that's your mistake. You should have opened it up, and that's the reason why you got that infection. And knock on wood, since then, I've done it exactly the way he told me, scoring it, opening it, get some vascularization in there, and I haven't seen an infection. So there are a few other questions, but unfortunately, we're out of time. I want to thank the panel. Every single one of you was just amazing. Thank you so much for all the experience, all the tips, all the profound points that you've given us. Hopefully this has been incredibly useful for all of our audience and our membership. Please don't forget about these labs and the annual meeting. If you need any more information, you can always ask the PSPS staff to give it to you. Thank you for the time. I hope you enjoyed it, and have a great evening.
Thank you.
I want to also thank Kaz for hosting the event. Appreciate you as always, Kaz. Always so well spoken. Thank you for leading the discussion. It was amazing. A lot of good feedback.
My
Thank
pleasure.
you.
Thank you so much. All right. Have a good night. Bye-bye.